Welcome to my postnatal maternity ward setup. I want you to understand what busy really looks like, what a day-to-day looks like on a maternity ward, what the staff to women and people and family ratios are on maternity wards in the postnatal period, and why we are in the place that we are in relation to the maternity crisis that is ongoing. Now, as a starting point, babies are not counted in any ratios whatsoever on postnatal wards. The only place they are counted are on neonatal intensive care units and in transitional care units. Otherwise, what is expected is that the woman or person who's just given birth, who's in her caesarean birth recovery, is looking after and caring for her baby. And only units that include some acuity apps will include the care provision that's needed for babies, but otherwise babies are not classed in the bed ratios. The best staffed maternity wards are 1 midwife to 6 women or people. The worst are 1 to 10 women or people, not including their babies. Average postnatal maternity ward runs on 1 midwife to 8 families at any one time. If we take the same amount of families that we have at the start of the shift at the end of the shift, that equivalates to 1 hour and 15 minutes worth of care per family per every 12 hours of shift. So each time a family is admitted into the postnatal ward, they get 1 hour and a quarter's worth of care if we were to evenly space it amongst everybody. So essentially in a 24-hour period, that's 2.5 hours worth of care per family. Now, the turnover of families is really high in maternity services. So what this actually means in reality is that you could have potentially cared for 10, 11, 12 families in a shift, because you would have discharged maybe 4 people and 4 people from delivery suite would have come in their place. So actually the reality is, because of that high bed turnover rate, families get even less care than that per every shift. Welcome to my maternity ward. So we have 24 beds on this maternity ward. We have 3 midwives and we're really lucky. We have got 3 maternity support workers. So each area of the ward is staffed by 1 midwife and maternity support worker, which is an amazing service. It's 7 o'clock in the morning, so we go into handover and we have handover of the 8 families that both the midwife and the maternity support worker is going to take handover for. Now, we also know that on delivery suite they are running out of beds. They've only got 2 beds free to be able to take anyone who comes into labour or any inductions that need to come up. And they've currently got 2 families that really need beds ASAP. So we're going to need to prioritise the homes and the people who are going home today. So it's 7:30. The midwife is going to make her plan of care for the day. She's going to go through all the drug charts. She's going to go through all the doctor review lists, all the baby checklists that need to be done that day. She's also going to make sure that the coordinator, whoever that is, whether that's on delivery suite, for example, whether that's on the ward, is updated with those who are going home, those who we have got any concerns about. Maybe there's been concerns with any observations overnight. Maybe it's that babies are not quite well enough, for example. Anything that needs to be escalated gets flagged up at that stage. So it's 7:45 now, and what's going to happen is the maternity support worker is going to go around each single room, take away any breakfast trays from having had breakfast, check that everyone has eaten this morning already, and also ask about their beds and whether they need any bed changes. The midwife is going to go around 1 family at a time in all 8 rooms and ask them, are you okay, and make those introductions. Now, we have 8 families. We're going to go with a 50% caesarean birth rate, which is currently stood at the moment. So we have got 4 families who have all had caesarean births. We have got 1 day 2, we've got 2 day 1s, and we have got a day 0 who came round first thing this morning from labour ward. We've got 1 family who is day 5, who needs lots of extra things doing today and is also high risk safeguarding, so needs social service involvement and needs a discharge planning meeting today. We've got 1 who's had an instrumental birth, and we've got 2 vaginal births here. So the midwife goes around each room and says, hello, I'm Angie, I'm your midwife for today. They say, how are you? And assuming that that individual family are okay, you can probably move around all 8 rooms within about 45 to 50 minutes, all documenting that you've made your introductions, you've said who you are, make sure they've got their call bell, a jug of water, for example, make sure they have eaten that morning. So we're looking at about 45 minutes to an hour. Now, if the midwife goes into any single one of these rooms and that woman or patient or family say, I've got concerns about feeding, for example, or bleeding, or I'm in pain, or I need this, you're going to add at least 5 to 10 minutes per family with whatever concerns that they might have at that stage. So we walk into room number 1, who's had a caesarean birth this morning. Her catheter needs to come out at 10 o'clock this morning. The midwife asks her if she needs anything. She says she needs some pain relief, so the midwife's going to go and get that and bring that back to her. This has taken 20 minutes so far. Her baby is on blood sugar observations, so we take the blood sugar test and we help mum to feed. We walk into room number 2. She really wants to go home today, but she's yet to pass urine. She had a catheter out at 4 o'clock in the morning. So we make sure that she's got a full jug of water and then encourage her to pass urine as soon as possible, when we can then sort out baby checks, mum checks, and then start thinking about discharge home a little bit later on this afternoon. We walk into room number 3 and she's desperate to get home. She wants to see her other children, and so she wants you to prioritise her discharge as soon as you possibly can. You say you've got to get around the other 5 women in your bay, for example, and then come back and do the discharge. You walk into room number 4 and she's really struggling to breastfeed. She's got sore, cracked nipples and she's really struggling. She's desperate to breastfeed. She really wants to do it, but her baby's got a tongue tie. And so what you as a midwife now need to do is start thinking about infant feeding referrals that you can do. So you go back to your maternity support worker, who's now got around all the breakfasts and the bed changes and stuff, and asked if your maternity support worker can go and give some really good infant feeding support in that room, and also help with some deep latch techniques, for example, some creams, thinking about pumping, expressing, hand expressing, etc. So your maternity support worker is now working with that one room. And now you walk into your 4-bedded bay. You go into the woman who's had a forceps birth and you ask her how she is. She says she's in a lot of pain and discomfort and she feels like everything's really heavy down below. So what you ask is, could you quickly do a postnatal check on her, check her stitches over, see if you can offer her some pain relief as well. And you check her stitches over, they look okay, they look bruised and swollen, but you're giving some pain relief to be able to help with that. And you discuss all the things that you need to discuss relating to her postnatal check. She also asks, I'd be more comfortable at home, can I go home today please? And then you walk into this room and they've said that they need a discharge planning meeting, which you're going to plan for 3 o'clock this afternoon. And because it's 10 o'clock, you've worked with your support worker to make sure that all the mums who need observations at 10 o'clock in the morning have them, make sure the baby observations are being done as well. And your last 2 beds, the mums are in purely because babies are on observations for group B strep here and IV antibiotics because there was potential sepsis in labour. So these babies, this one's on 2-hourly observations, this baby's on 4-hourly observations. Now that all the observations are done, this woman here in room 1 needs her catheter removing. So the maternity support worker goes back to do that and advises the woman to be able to pass urine in the next few hours. She also helps her out of bed. Go back to this room and you get on and discharge and you do all their postnatal checks, sort out their medications to take home, make sure that they've had a doctor's review, check the notes to make sure there's no follow-ups that need to be passed on to the community midwifery services. You make all the follow-up referrals to community midwifery and they go home. The midwife then discusses with the infant feeding team, can we make a tongue tie referral for room 4 because we will need the bed at some point given how busy delivery suite are. Now you have got a new patient in that bed who has taken over because they need the rooms on delivery suite. You take handover, you say, hi, I'm Angie, I'm your midwife, make sure they've got their call bell, their jug of water, check the baby labels, make all those documents on their documentation. The midwife goes into room 2, does her discharge bit, she's passed urine now, she does all her medications. We are going to make our midwife go and have a break at this stage. What this means is a midwife from another area now has oversight of 16 families at this stage, in conjunction with the maternity support worker who's giving out lunches at this moment in time. When the midwife comes back from her break, the maternity support worker goes off and has their break. This baby needs IV antibiotics. We've got all of the observations on the mums who are required and also the babies at this stage too. It's 2:45, we now have bed 1 who's come over from delivery suite and has taken up that last free bed. The midwife now needs to go and do a discharge planning meeting with social services and with everyone that's going to be looking after this family when they go home. After this meeting is over, which takes about half an hour to 45 minutes, there's a lot of write-up with that. This family now need blood spots, they need baby weighed and checked, but they can go home today. The maternity support worker goes in, does the newborn blood spot checks, does the weighing, and the midwife goes in, does the postnatal checks and starts to get this family discharged home. While she's doing those checks, this family here are also wanting to go home now. They've passed urine, they're desperate to get out the door. However, they need to wait until this family are discharged first. Once that family's discharged, they go back and discharge this one. This family have been seen by the infant feeding team and have an outpatient referral appointment made. The midwife has asked them to go and discharge this patient. It's 5:30, so the meal times are done and the midwife goes to do a medications round. So it's 6:30 in the evening, we've just done our medications round, we're about to start the observations round, we're down to 6 patients. This family are still desperate to get out the door and you're trying hard to get there, but you know that you need to hand over at 7 o'clock, so you're preparing everything ready for handover. What you think to yourself is that the night staff are probably going to need to discharge this family at this stage. At this point, you haven't even been back into these rooms. However, you know that your maternity support worker has answered call bells to them throughout the day to make sure that they are okay and checked on them. You're also aware that there's a catheter needing to be removed in this room as well, post-cesarean birth. And again, you liaise with your maternity support worker to go and do that. What we need is mandated safe staffing ratios, and they have just mandated this over in Australia, where you have 1 midwife to 3 families as an inpatient. What this means is those 3 families can have proper, in-depth, supportive maternity care that they require and need. To work as an average of 1 midwife to 8 families at any one time, remembering that there are always people who will fill those beds, so actually in a shift you are usually looking after far more families than that, is just diabolical, and it's not good enough. The very fact that babies are not included in the figures, in the numbers, is appalling. And to be an inpatient as a family and only to get 1 to 2 hours per shift maximum of care from a midwife is just diabolical, and it shouldn't be happening. What we need is safe staffing ratios here in the NHS, and this government don't seem to be interested either in safe staffing ratios. If we start mandating safer staffing ratios, midwives can get break, the retention will actually improve in maternity services, midwives will stay, they will be able to provide the level of care that patients and families need, instead of going, I'm really sorry, I can't answer this right now, I can't do this, I need to go in and do baby observations, antibiotics, whatever it is in another room. People will not feel dismissed, they will feel heard and listened to. Give midwives and maternity support workers the time, give them safe staffing ratios where they can provide adequate support and time to listen, and we will start to see the maternity crisis improve. Really simple. Just provide more staff and provide safe staffing ratios 24/7, protected meal times, protected staff times, and here we go. Crisis solved. Everyone benefits.